didactic at the end is on a very different topic. It's about a educational program for middle school and high school students that has to do with giving them information to make better informed decisions about vaping or not, and using tobacco products or not. But with that, with Dr. Sharma here, let's go ahead and do the case.
All right. So Dr. Doyle, I do think I was able to pull the two images you submitted. I hope they're correct, but whenever you want those, just let me know and I'll pull them up.
Okay. I actually think those images don't go with this case, Caitlin, but we could probably pretend they do, even if they don't.
Okay.
Okay, so this is a case of a 74-year-old man. Is it okay to say what town he's from, Caitlin?
Sure, if it makes sense for the case.
Well, I mean in terms of de-identified. Okay, so this 74-year-old man from Beckley, West Virginia, worked as a coal miner all his life, stopped working probably 15 to 20 years ago, and he did have come to us both for black lung benefits counseling and for pulmonary rehab. He completed pulmonary rehab at this Grace Ann Dorney Pulmonary Rehabilitation Site, probably in 2014 or 2015. Because he has federal black lung benefits, he's able to keep coming back on a twice weekly basis, and we can get paid for it. And Eric, that's one important way of sustainability for some of the GADPRC sites when people have federal black lung benefits. Yeah, so he's one of those people, and he comes very faithfully twice a week to keep up his maintenance. He has a lot of, but he has a really hard time. He has a lot of exacerbations where he needs antibiotics and steroids and more frequent oxygen or higher flows of oxygen and more frequent use of his nebulizer. So we see him all the time. And his clinical course has been, over the past few years, gradually declining, more and more short of breath, even with his oxygen. But he has not been hospitalized, as I can recall, for a while. Can you just scroll down, Caitlin, and see if they're HPI? Okay, so I don't have a whole lot of, wait a minute. This is the wrong, I'm sorry, this is the wrong one. A whole lot of stuff is missing here. Okay. So I don't know if you can, but maybe let's keep going with what we've got. And if you're able to find the version I sent in on Wednesday and put it up with more history, that's great. And if you can't, that's okay. Okay. So in the section there that says HPI, there's a whole lot more on the form that should be there. But basically what it says is that his other conditions, well, there they are: severe black lung and COPD, coronary artery disease, and he did have a previous myocardial infarction. He was not a candidate for bypass surgery or stents, so he didn't get those. He has type 2 diabetes. He doesn't take insulin. Let's see. The gallery, there we go. He has not had a stroke, doesn't have dementia, he's on oxygen. Unfortunately, he still smokes, hard as that is to believe. And then it's, okay, yeah, let's take a look at his x-ray. You can put that up.
So let me see. Give me 1 second.
Or why don't I finish this?
Okay.
Let's finish this, and then we can look at the x-ray, which, well, actually, the x-ray, the only thing I had for this was just a text description of the x-ray. I know I didn't have an image, so that image doesn't go with this case.
Okay.
Okay, his spirometry, this looks better than the other version. And is there one down below too? Yeah. Okay, so if you go back up, no, this is what I sent. This is good. This is the second version. So anyway, here's his spirometry. And Caitlin, I think what I did was to attach a file which has the whole spirometry report. So maybe let's take a look at that. And I think on this call, of the people that we have right now, I think about the only person who I would put on the spot to interpret spirometry other than me would be Dr. Sharma. So Dr. Sharma, if you can see that, would you sort of take us through this spirometry?
Yes, sure. So what I see is a full spirometry with lung volumes, diffusion capacity, and spirometry going by segments. If you look at the spirometry, your forced vital capacity, assume the first segment is predicted, and his best is 4.16, which is not bad. It's about 106% of predicted. His FEV1, although, is 0.97, which is less than a liter, but only 34% of predicted for his age, giving him a ratio of 32%, which is consistent with very severe COPD by Gold classification. There is no significant change which would be defined as over 12% improvement in FVC or FEV1. Though there seems to be a little bit changes in his small airways, but still doesn't reach up to the level expected from bronchodilator response point of view. His lung volumes, his total lung capacity is 103% of predicted. So we suggest that there is no concomitant restrictive lung disease that we can see in that, which sometimes you can see with cold minus disease or concomitant interstitial lung disease, along with an obstructive component in the disease format. But lung volumes do suggest that significant amount of air trapping, actually it's not too bad. His residual volume is actually 108%. So residual volume per DLCO 104, he doesn't have too much of air trapping, but his diffusion capacity is severely reduced at only 33%, which explains why he's on oxygen at this time and has, consistent with his spirometry, a very severe and advanced COPD type of picture. So in a nutshell, I would say this whole PFTs is consistent with the severe obstructive lung defect with significantly reduced diffusion capacity.
Okay, great, thank you. And can you just zoom out on this view, Caitlin? So, so actually this spirometry, is that it? Is that all you can do? Oh, there we go. So this was actually, you can see at the bottom there, it was done on March 24th, 2016. So it's actually 3 years old. And here's what the PCP, here was the PCP interpretation of it. The spirometry with bronchodilators, severe obstructive impairment, not significant improvement after bronchodilators, lung volumes normal, DLCO severe reduction. So by any criteria, severe obstructive disease, and as Dr. Sharma said, not evidence of restrictive disease. So then can we go back to the case view? And if you go down to the bottom, so then where it says questions and comments, I said there, at his follow-up visit last week, his pulmonologist, Dr. Haddadin, recommended referral to the interventional pulmonologist at Cabell Huntington Hospital for endobronchial valve therapy. They want to know, what do I think? And what I did was to sit down with them, and we all looked at the computer screen together, and we actually went to PubMed and looked up what we could find together about endobronchial valve therapy. And then I tried, and I found a couple of a few good articles. There wasn't a whole lot, but there were a few good articles. I forget if there's a Cochrane review on this or not, but there are some systematic reviews. And when you look at PubMed, which is the National Library of Medicine, it's online, free to the world, wonderful place to be actually able to look up original research on questions about treatment like this one. You can get the abstract of the article. And so I looked through those with them and tried to translate the medical jargon into common language and explain it to them and explain how this works. So, but there wasn't enough there for me to feel like I understood this well, and it was really almost my first time of hearing about it. I will say that I went to the website of Cabell Huntington Hospital, where I saw that there was one physician who was doing this, and Cabell Huntington Hospital was, I'll try not to use a derogatory verb, Cabell Huntington Hospital was announcing that they are the only place in West Virginia that does this, and so it was definitely marketing it objectively or aggressively, and it made me a little bit worried if they weren't up to capacity yet about feeding my patient into that. On the other hand, and the patient and his son were worried, and one of the things we went over in the systematic reviews was adverse effects, and there are some, but still I feel like I've barely scratched the surface. So Dr. Sharma, it would be great if you could sort of tell us about this, and I'll hold off on telling you what my advice was to the patient.
Sure. So that's a great question. And, you know, in the world of COPD, where, you know, you recognize just about 10, 15 years ago, we had very little options, including very little armamentarium as far as medication. We had significant advances in managing COPD. So one of the new modalities which is coming up, and we are getting more information regarding that, is the endobronchial valve placement. And it goes back to our information and knowledge about lung reduction surgery. So if we were to go back and look at some of the physiological changes which occur in patients with COPD, one of the devastating consequences of COPD is the creation of bullae and cysts all around the lung. Sometimes these occur in a very diffuse fashion, generally located in the upper lobes, but sometimes they can be pretty lopsided and unilateral, or involving just one of the lobes. One of the adverse consequences of these cysts and bullae is that these are nothing but empty spaces, and as they grow, they push and they compress the normal lung. So not only are these cysts and bullae not involved in air exchange, but then they push on the normal lungs. So whatever other areas of the lungs which could have contributed to lung air exchange, they also are incapacitated in some way. So that makes a patient more short of breath, more oxygen dependent. So the idea a few years ago was, what if we were to remove surgically these dead spaces and bullae and let the rest of the lung, or at least whatever is left of the normal lung, expand and be able to participate in the lung exchange. And that led to, I'm pretty sure aware of, the lung volume reduction surgery. And, you know, it was very promising at some point, but then we realized that these patients are so advanced that they were much more impact of the surgery post-op on these people, then they were benefiting. And there was a very small segment of patients, as I just alluded to you, who had very unilateral cysts and bullae. Majority of the patients with COPD, as you've probably seen hundreds of x-rays and CAT scanning these patients, it's a diffuse process. That's why there was a limitation of the lung volume reduction surgery, and that's why it lost it. So considering that there's significant morbidity, these patients are advanced COPD patients, they generally can't undergo anesthesia, surgery, and those kind of intense intervention. They came up with a medical version of the surgery called the endobronchial valve. So endobronchial valve is a similar type concept as lung volume reduction, where they identify a certain area which is basically nothing but a dead space and is not contributing to the airway exchange. And what they do is they endobronchially go in and they put a valve, and that valve prevents air from getting trapped into that particular cyst or bullae. And the idea is that majority of these patients who have bullae, there is a one-way valve where the air goes in, but it gets trapped, and these bullae are getting bigger and bigger, and they're contributing patients' morbidity and shortness of breath. But if you could block them and prevent them from trapping air so that these valves can actually deflate some of these cysts and bullae, then you would have more lungs participating, hopefully, and reducing the amount of work of breathing in these patients. So that's the kind of generalized concept against this new technique of endobronchial valve. The advantages of it are very clear, that the patient doesn't have to go through tremendous amount of surgical procedure, opening up the thoracic cavity, or also having deep anesthesia. Some of these patients are so advanced COPD that once they go into anesthesia surgery, they get placed on a ventilator for a prolonged period of time. All of those things can be avoided, and this can be done as an outpatient. The problem comes in is that, in the trials which were conducted for the endobronchial, valve placement, there were significant large amount of patients, almost 20% or more, who would get a pneumothorax, considering when you put a valve and the exchange is not appropriate, you would lead up to a rupture of some of these cysts and valves, and they can cause a pneumothorax, and some of these can be deadly. Majority of those pneumothorax have been found, at least by our experience, to occur in the first 3 to 5 days, which has led to this procedure being now an inpatient procedure, in which the patient is mandatorily required to be observed for 3 to 5 periods of days in the hospitalized environment. That has become a little bit of a limitation. Again, there have been preliminary data, including randomized controlled trial, that the patient has benefited in terms of improvement in his symptoms and as well as FEV1. Again, these have to be replicated. We need to learn more about as a post-marketing data isn't out there yet, since very few institutions are doing it at this time. But that's is kind of in a nutshell what in the endobronchial region. These have to be very carefully selected cases. So it's very, very important to have the right person who would benefit from this procedure. The way most of these patients are screened is one having a high resolution CAT scan, which can show us whether they are unilateral bullae, which are causing these kind of damaging compression, and the patient would be benefiting from placing a valve there. The second important way is to make sure that many of these cysts and bullae, they are actually communicating with each other inside the lungs. And it is important to find out whether that communication exists or not, because that directly links to their chances of getting a deadly or fatal pneumothorax in the future, and also about the success of that procedure. So that's a very carefully conducted trials. Some of this is done at the time the patient is undergoing the procedure to see if there is any valvular connections, and that sometimes can be pretty dangerous. And then what it needs to happen is to happen in centers which have a lot of experience with that. And that's why it is not something which should be taken lightly. I keep telling them we are still waiting for a lot of post-marketing data. So we don't know overall how this is going to turn out. So there's always, any new technique has to be taken with a grain of salt. Number two, you can cause fatal complications with this procedure if you're not careful, and if you don't understand the process that these valves can be having channels and communications between themselves, which could be pretty dangerous. And that is not an exact science. It requires a lot of work in tandem with radiologists as well as interventional pulmonologists to figure out whether these cysts are communicating with each other. That's number two. So these are some of the limitations which we have. So we are very careful when we are selecting these patients. And at this point, I think it would behoove most of the pulmonologists whose centers haven't done a whole bunch of them to maybe refer to centers which have done a large amount of these procedures to make sure that we are treading in the right direction. And as we get more experience, just like any other science or procedure in the past, it can be expanded to other centers which currently are not doing it on a routine basis. So that's kind of a brief outlook of endobronchial valves. Happy to take any questions.
Thank you so much. That was wonderful. We really appreciate that. Guys, do you guys have any questions out there in the world?
Are we still communicating?
Yeah. All right, Dr. Doyle, do you have any questions?
My philosophy, there's always questions if you give people enough time. Well, one thing that was a bombshell for me that you just said was about the communication between cysts.
Right.
That's the first time I ever heard that about that sort of lung pathology or pathophysiology. And so that's interesting in itself. And then is the idea that so these endobronchial valves are basically one-way valves. And Mitra or Caitlin, could you see if you can find a picture of this? Let's see if we Google this and then look at images. We'll probably get about 50 images, but let's see if we can find one that gives people a picture of this, because truly this is where a picture's worth 1,000 words. But Dr. Sharma, were you suggesting that that by putting a one-way valve in, putting a one-way valve in is not going to cause the cyst toward which the one-way valve is directed to hyperexpand. On the contrary, it's going to have it de-expanding, or the idea is it would de-expand. But what is it about those communications that increases the risk of pneumothorax? And were you saying that the risk increases if there are significant communications, the risk increases when you do this procedure?
Right. So let me first go back and clarify something. If you look at the image over there, so the main pathology when you're talking about advanced COPD,
and we don't see it yet.
Yeah. Okay. Let me. Is this a good one?
Yeah, that could be a.
Okay.
But go ahead, and if she can get it up, she will.
So in any sense, let's go back to the pathophysiology of COPD, where there's basic pathophysiology of destruction of the terminal bronchioles, which basically means you have no problem inhaling and filling the alveoli, but when you're exhaling, the terminal bronchioles collapse and that trap the air in the alveoli. So as time goes by, these alveoli, they continue to expand like balloons, and they self-destruct themselves, which is kind of the pathophysiology of these cysts and the villi, which we see in this disease. So it already is a one-way valve. It is easy to get air in, but very difficult to get air out. So what I alluded with these valves was that when you place these valves, and you can see one of them being placed in there, is basically prevents the collapse of these airways, so prevents air trapping. So these patients can then easily exhale. One of the biggest problems with COPD, if you look at why they get short of breath, and you would say, well, they don't get enough oxygen. That is correct, because there's not much exchange of oxygen with the alveoli. But another reason why these people get short of breath is because of increased work of breathing. Why is this increased work of breathing? Because your alveoli and cysts, they have expanded. The air goes into the alveoli but doesn't come out. So what it does is this trapped air causes increased PEEP, or increased positive airway pressure. Now, all of us know the only way we can breathe is by creating a negative pressure. That's basic physiology 101. If we don't create negative pressure into our pleural spaces, the airway from the atmosphere or air from the atmosphere will not flood into the lungs. Now, imagine if your airways are trapping air into the alveoli, it is becoming positive pressure instead of a negative pressure. And a positive pressure cannot suck in air. So these people have to work harder to generate that negative pressure from their diaphragm. And what you and I can accomplish in 1 or 2 breaths, these people probably need 8 or 10 breaths for the same amount of breath. So the more negative pressure you have to generate to fill your lungs, the more tired you can get quickly. And that's the pathophysiology. So if you can have less air trapped into the alveoli, if you can have less air trapped into this bullous and cyst, you have less diaphragm working and better improvement in your functioning capacity and your breathing capacity. So that's where this valve comes into play, is decongests and prevents that positive pressure building because of the air trapping. So the one-way valve is what is already existing in a bad COPD lung. And this valve basically decompresses as kind of a valve in which, in a way, it is one way because it only opens up when the positive pressure in the alveoli and the bullae or the cyst develops quite a bit. If you can understand that, is that if you take it as a balloon, as the balloon continues to stretch because of air getting inside, only 2 things can happen. One, the pressure exceeds the capacity of the balloon and the balloon bursts, which is your pneumothorax, or a catastrophic fatal outcome. Or you release some of that pressure by opening the airway of the balloon, so the balloon decongests. And this valve does exactly the same. When the pressures go to the point where the lungs cannot handle, this valve will open up. That's why it is kind of a one-way valve, is because it decompresses when the pressures go high. Now, I think there was a part B of the question, which I'm assuming was the fact that communicating channels, how do they interact with this pathophysiology? So imagine if these 2 balloons are connected through these microchannels. So you have a balloon which is overstretched, and you have a valve which will decompress anytime it stretches. That is a good position to be in. Now imagine a scenario. You have 2 balloons, and both of those have microchannels communicating between each other. Now, what happens is that balloon, when it goes and increases the stress, instead of opening that valve, transfers some of its pressure onto the next balloon. which is communicating with that. That other balloon doesn't have those valves. So it is continuing to stretch now even more because the valve is there and is preventing other channels from communicating. So it is a one-way traffic where the pressure from a balloon is being transferred to another balloon, which is communicating with that person. And that balloon then has a tendency to burst, and that can cause fatal pneumothorax. Does that make sense?
Yes. Well, that's for me. Anybody else? And actually, yes, thank you.
So in essence, our job as interventional pulmonologists to make sure that that balloon, and I'm just using very simple language, is of course these are much complex cysts and bullae, but if you take the analogy and you follow the analogy of a balloon, my job or interventional job is to make sure that balloon isn't communicating with other balloons, that I'm not just transferring that pressure to some other part of the lung, which cannot take that pressure and will collapse and will cause fatal pneumothorax, sometimes very, very deadly.
Caitlin, I'm the one who's guilty of making the case go too long today, but it's great to have Dr. Sharma explaining this to us. But let's give people 30 seconds to see if there are any other questions about this, and if not, go ahead and see what we can do with our didactic.
Certainly. Everybody, any other questions? Dr. Sharma, we really appreciated having you today. That was great.
Thank you. Appreciate that. Thank you for having me.
Yeah, you saved the day.
Yeah.
No. You guys are doing the hard work.
I'm so happy to have some new people on this call. Do you guys have any questions?
Actually, speaking of new people on the call, I know from who's on the call that somebody at Cabin Creek was organizing to get people to come to the Echo today, and I'm guessing it's you, Craig. So what's going on there? You have to unmute to talk. He might have gone away and done some other work, but Tammy and John and Craig are all from Cabin Creek, and John's been with us before. I'm not sure if you have been on this one, Tammy. You've probably been on other Echoes.
I don't know if they can talk or not. They may be in an open office. Tammy joins us a lot for hepatitis C and.
Yeah.
Yeah, that's right. This is the first one.
For lung disease.
Super happy to see you.
And Diane Carpenter, you're going to get to meet me and Craig this Thursday, because I think you're coming to our meeting in Maryland.
Yeah, that's correct.
Great. So we look forward to seeing you. I'm glad you could be with us for this.
Well, thank you. I'm looking forward to joining more of these.
So a good segue to our didactic, and which we have about 15, 20 minutes for, is what Dr. Sharma just said about you are doing the hard work. And that's nice of you, and we are all doing hard work, but we know that you are too. And in a way, this didactic is about us in our role as teachers, because all of us in one form or another are doing teaching. In the case of the University Hub members, you have patients and you teach your patients all the time, but you have a formal role of teaching medical students, nursing students, pharmacy students, respiratory therapy students, residents, fellows, and often going to national or even international meetings. And so you tend to be teaching a lot in a higher medical literacy population. The respiratory therapists, the primary care providers, we spend an awful lot of our time teaching our patients. And there's one group of non-patients that we don't get much opportunity to teach, but this didactic in a way is about teaching them. Because one of our goals in the Appalachian Pulmonary Health Project is the primary prevention of COPD. And in order to do primary prevention, we have to either get people to quit smoking before it's too late, or even more important, have them never start smoking in the first place. And the past really almost 2 years, we've been really focusing on preventing first use of tobacco products. And that means working with middle school and early high school students. And we know that they're the ones who are most affected by the vaping epidemic that's going on right now, especially the Juul epidemic. So what we did at Cabin Creek and New River, but this is now spread out to a number of our other sites, thanks to funding from the Palatine Foundation of Huntington, is to find an outstanding national curriculum called Catch My Breath, which was specifically designed to inform middle school and high school students about the reality of vaping and Juul and the chemicals that are in it and nicotine, in the hope that they will make better health choices. And so I think, Caitlin, given the time we have, let's see if we can get to, there's about a 2-minute summary video about this program, and then a little bit long, about 8-minute video presentation that tells about it. And I'm gonna assume that most of you already know, because of the national publicity that's happened this summer and fall, about the scope of the vaping in high school and middle school students, driven a lot by social media, deliberately planted influential ads in social media, and really just focus on what is this Catch My Breath curriculum. So let's see if we can go to the Catch My Breath. And so what you do is you Google catchmybreath.org.
Whoa. Sorry, I'm having technical, my mouse is dying.
Well, you did great with endobronchial valves, so I'm betting you'll do fine here too. Now, let's go ahead and log in, Caitlin. And it's daniel.doyle at cchcwv.com. But actually back up a screen for just a second. If you would, yeah, okay. So if you Google catchmybreath.org, if you just Google catch.org, you'll get to the main Catch website. You'll have to find your way to this, because Catch is a coordinated approach to child health. It's a general elementary and middle and high school wellness curriculum for school health programs. And this Catch My Breath is a module within that. So you have to specifically ask Catch My Breath. But even without having an account, a person who goes to this, a school principal, a parent, can click on this little video, and it gives them just a 2-minute overview. So let's look at that first.
Okay, everybody, let me know if you can't hear it.
I'm not hearing it.
Okay.
Yeah, we do need the audio.
Oh.
Catch is
Now this isn't it. We kind of
Public
got
Health
off the,
and disseminated by Catch Global Foundation.
This looks good. That was good.
The program is best practices based and meets national academic standards, Common Core standards, and many state standards for health education. Catch My Breath has 5th, 6th, 7th, 8th, and 9th through 12th grade tracks. Schools may choose to teach the program in any grade or multiple grades, as each track is standalone. Thanks to funding from CVS Health, Catch My Breath is free to schools across the country. When schools enroll in the program, they receive access to all program materials through the Catch.org platform. The online platform allows the Catch team to keep all program materials up to date with the latest vaping products and science, as well as notify users when new resources become available. Catch My Breath consists of 4 lessons that each take 35 to 40 minutes. It's recommended that schools teach 1 lesson per week over the course of 4 weeks. The lessons are a combination of teacher presentations and peer-facilitated small group discussions and projects. Students will assess health hazards and dangers of e-cigarettes and Juuls, analyze personal influences and industry marketing tactics, and learn and demonstrate refusal skills. The program includes detailed teaching instructions, scripts, and PowerPoint slides. Minimal teacher planning is involved or needed. The curriculum can be taught in a variety of subjects including science, health, physical education, and advisory or homeroom. There's also a PE supplement that incorporates calisthenics and other physical activities alongside the core educational components and objectives. Before teaching the program, teachers are asked to watch an online training video. The video gives teachers a basic understanding of e-cigarettes and orients them to the program lessons and content. Schools are asked to participate in pre- and post-program teacher and student surveys. To learn more and enroll in the program, visit catchmybreath.org.
Okay, great. So let's just stop right there for a second. So in that 2-minute video, you saw that they were demonstrating the online platform for teachers and health educators like ourselves. And much of our work is, as I said, is educating patients. So many times that involves us translating and explaining medical information, sometimes even the medical information that's in the newspaper, often that's in the newspaper on TV, to our patients, like happened with my patient and his son who came in asking about endobronchial valves. And they'd just been to see their pulmonologist, but didn't have that good an idea of what were the potential benefits and risks involved. So a lot of our work is explaining and translating. But in terms of what you just saw there, any questions or comments about that? And are there people who already are aware of this curriculum or have even had hands-on experience with it?
Eric has? Is that what you're saying, or?
Dan, what's
Yeah.
the cost of using and deploying that curriculum?
Well, that's the great thing, and it kind of flew by in that 2 minutes where they crammed a lot in. They say there's no such thing as a free lunch, but this actually is free because of the CVS Foundation, which has made a grant to the Catch Foundation, which is a nonprofit, that actually makes this available free to all the schools in the country, at least as long as that funding lasts. And it seems pretty stable at the moment, so it's free. Okay, so then let's.
And
Oh, go ahead, Eric.
Dan, how much do you know about sort of results? I mean, you described it as evidence-based, or they did in the video. So like, does it actually prove to delay initiation or prevent it altogether? I assume, but what kinds of things are measured?
What is measured is that they have students complete an online pre and post survey that talks about their current vaping use, how likely they are to start vaping in the next year, what they know about vaping already, beliefs about what percent of their peer group is actually vaping, and what they have been able to demonstrate so far. And there's a slide, and I don't remember the exact statistics on this slide, but the slide shows that the average, I think it's 7th grade class in the United States, consists of 170 students. And without this educational program, of those in the next year, something like 25 will begin vaping. And with this program, based on the students' stated intentions, so self-reported intention after the course, that number is reduced to 17. And I think they projected that onto a national level, that would, if all students in all schools were getting this, that would prevent first use by around 180,000 students. So far the evaluation is based on self-report of intentions or current active use before and after the course.
Great. And it's emphasizes vaping over cigarettes or both? I mean, it seems like you've talked more about vaping.
Right on the screen there, Catch My Breath, e-cigarette, and Juul prevention program. So this particular program zeroes in on vaping, e-cigarette use, not to the total exclusion of cigarette smoking and using chew tobacco like dip and chew. But this is 95% focused on e-cigarette because that's the epidemic in the middle and high schools right now.
Okay, thanks.
Yeah. So let's go ahead and log in, Caitlin, and I'm going to give you a little bit more look at what's available here. Now we can do Daniel Doyle at Daniel.Doyle at CCHC. Go ahead. So when there's a teacher, or we've been getting FQHC providers to actually create their own account and log in and look at these materials. And one of the things they can do is very easily get certified. And on this project we're working on right now, actually, one of our goals is to train the trainers, and our outcome measure for that is it's COM, Caitlin, not ORG. There you go. Okay, and it's the password is capital P RIM PREV 2. Let's see if we can get in. Wouldn't you know? Let's try that password again. cchcwv.com. Capital P RIM PREV, so prime prev 2. Try it. This is anything that can go wrong. Well, let's so can you put up that PowerPoint I showed you?
I don't know.
Or I gave you? And I think in that PowerPoint I have the slide that answers the question Eric was asking about impact. And actually, when that sort of flew by, that 2-minute thing flew by, they mentioned that this was developed by the University of Texas at Austin School of Public Health. So they're the ones that got the funding, developed this, made it available.
Dr. Doyle, it actually won't let me pull it up. The PowerPoint is too big a file to save.
Oh yeah, it's 22 megabytes. Sorry about that.
No worries.
Okay, so so that's it. There's this there's a Catch My Breath curriculum. We applied for we being Appalachian Pulmonary Health Project Partners in Health Network applied for funding from the Palatine Foundation of Huntington, basically saying we were going to get this out through the FQHCs that were part of our network. And so we're right in the process now of working with Southern West Virginia Health Systems, which has school-based health centers already in Lincoln and Logan counties, the Williamson Health and Wellness in Mingo County, Cabin Creek in Kanawha County, and Big Sandy Healthcare, which is in Eastern Kentucky, and Martin and Floyd counties. And they're starting this program right now. And so we've been able to have Catch My Breath agree that the online surveys that the students do, which are completely de-identified, but are identified as to what school they're at, that they're going to share that information with us for our evaluation. So we will be able to have that data and feed it back to the school, so that a school that does this with, say, 7th, 8th, and 9th grade will be able to see how many students they had who participated and what their students said before and after. and then we'll be able to aggregate it from all the schools. And we'll also be able to do it by county, and we'll be able to aggregate it from all the schools as part of our overall evaluation for this funded grant project. It's a 2-year project. And we're sort of thinking in terms of this project lasts 4 semesters. We're in the first semester right now. Spring semester 2020 will be number 2, then fall next year, and then spring the year after that. And so we will keep you posted on how it goes. And that's the conclusion of what I have.
That's great. Thank you so much, Dr. Doyle. Does anybody have any questions? I know we've talked a lot, which is wonderful.
What's next?
Well, we have 2 minutes left. So
I mean, our next echoes.
our next session is going to be on the 16th. We don't have a case yet, so I would really love to have a case if you guys have one. This is our last one for 2020. And we also don't have a didactic plan, so if you guys have any questions about what you'd like to hear, I can totally make the request. You should have all gotten the flyer for the upcoming year, the first 6 months of 2020. So I will send that again. We will send that again with the recap. Dr. Sela is going to start out the year for us on January 6th, I believe. And she's going to talk about NICE guidelines. So that'll be coming up shortly. And then in January, actually, we have a shortish month because the second one would fall on Martin Luther King Day, and so we won't have it. So.
One comment about what Dr. Sela is going to do, the NICE guidelines. Here in the US, we're used to the idea of the NIH, National Institutes of Health. NICE is an acronym for, I think, National Institute for Clinical Excellence. And it's actually the agency which gathers comparative efficacy research for application in the National Health Service in the United Kingdom. So NICE, their NICE guidelines tend to be very practical. And we have the GOLD guidelines, which we've used a lot for COPD, but there's a NICE guideline, a National Institute for Clinical Excellence, and so she's going to be going through that with us.
So that's that. Everybody let us know if you have any other topics. And again, we would love to see some more cases, even simplified cases. I know sometimes it's daunting to submit one, but you guys can submit a question and I can help you fill in anything if there are questions. And Mitra is now here to help us. So we have double the effort now. But everybody have a happy Monday and a good week and stay warm.
Thank you very much.
Thank you.
Thank you.